Hi, and welcome to your first lecture of our sonography class for working sonographers. We're going to start with our first class in this series is going to be looking at gynecologic scanning, and then we'll follow up this series with a secondary class in obstetrics and then abdomen. So thank you for joining us for the first part of the series. We're excited to have you here, and we hope that this class will serve as an overall review of all of the most essential content for the gynecologic system. Hopefully this will not only prepare you for better scanning, but will also prepare you if you are considering taking your OBGYN boards. So we hope that you enjoy the course, and we're going to start in today by looking at the female cycle. As always, if you have any questions, please reach out to Erica or myself, and we'd be happy to help you in any way that we can. My name is Rainey Hatman. I'll be teaching your lectures. Erica Salazar is our lab instructor, and she'll be coming out to do some hands-on time with you to help make sure that the course has helped you meet your objectives. Our objectives for this initial lecture is to describe the physiology of the menstrual cycle, identify the hormonal changes that occur during the various ovulatory and endometrial phases, explain ovum development and its passage from the ovary to the uterus, and discuss the function of the female cycle. And as part of this initial lecture, we're going to go over a little bit of our anatomy as well, do a brief overview just to make sure that when we're talking about the specifics of this, that we're familiar with what all the terminology means. So our reproductive anatomy, we're going to be kind of all over the body today. So we're going to be looking at some endocrine anatomy that's going to be essential in operating or maintaining the female menstrual cycle. So the endocrine organs that we're going to be really paying the most attention to is our hypothalamus, which is located up in our brains, our anterior pituitary, which is located just anterior to the hypothalamus and sits in what we call the sella turcica, and then our ovaries, which act as not only our gonads, but actually as endocrine glands as well because of their release of progesterone and estrogen. We're also going to look at the different parts of the uterus to include the fundus, the corpus, the isthmus, and the cornua. We'll look at the cervix and its internal and external os, as well as our endocervical canal. We'll evaluate the fallopian tubes, including the isthmus, ampulla, infundibulum, the cilia that line the tubes, and the fimbriae at the end of our tubes. We'll talk about the vagina, including its fornices, its canal, and its orifice, as well as the female gonads, the ovaries. It may actually be beneficial as well to take a look at the ligaments and muscles, but we will follow up with that in a subsequent lecture. So when we're looking at our anatomy here, just a really quick overview or review. Here you see the fundus of the uterus. This area just below where our fallopian tubes exit our uterus can be called a transitional or a cornual area. Then we have the body or the corpus, and then the cervix, that musculofibrous area at the inferior uterus. The cervix has an internal os which opens up into the endometrial canal, the endocervical canal, connecting that internal os to the external os, which is then going to open into the vagina. Our vagina here, this would be the body of the vagina. It's usually 7 to 9 centimeters long. On either side of the cervix, it attaches slightly higher than the inferior cervix, and we call these little pocket areas the fornices or a fornix. When we look at the fallopian tubes, we know that they connect here in the cornua of the uterus. This will sometimes be referred to as the cornual area of the uterus or the interstitial area. The initial large part of our fallopian tube is our isthmus. As it comes towards the end, it broadens out to become the ampulla, and then it ends in these finger-like fimbriae, which are going to sweep up the ova when ovulation occurs. Most fertilization is going to occur back here in the ampulla area. If we look at our uterus in the different layers it contains, we have the parametrial outer lining, which is made of serosal type material or fibrous material. Then we have 3 layers of muscular tissue that makes up our myometrium. Now those layers are going to run vertically for one layer, horizontally for another layer, and in a spiral orientation for the 3rd layer. And that variety of muscular orientation really allows the uterus to be an amazing contractile organ, which if we're thinking about the role of the uterus in giving childbirth, that's going to become very, very important. If we look at the uterus here, you will usually see, and it's not documented on this image, but you'll see uterine arteries come up the sides of the uterus. Those uterine arteries will then penetrate into the myometrium all around the uterus, and once they do that, they're referred to as arcuate arteries. So we would see uterine arteries spiraling up from the cervical region upward, and then branches off of those uterine arteries come in, those become the arcuate arteries. As they get nearer to the endometrial canal, they actually change into what we call the basilar arteries, or pardon me, the radial arteries. And then ultimately the endometrium is made of what we call the spiral arteries. And those are the arteries that are going to slough off during menses and then regenerate throughout the cycle. Now, you also see here that this ligament that you see kind of draping over the fallopian tubes, this is the broad ligament in here, and this attaches to the ovary. We also have the ovarian ligament that attaches the ovary to the uterus, and then the suspensory ligament which attaches the ovary to the lateral pelvic wall. The uterine layers, as we just discussed, consist of the parametrium, that serosal outer coating, our 3 layers of myometrium, our longitudinal, our transverse or axial, and our oblique. And then, of course, the endometrium, which is our regenerating and degenerating layer during the menstrual cycle. Now, our ovaries, on the other hand, are located laterally to the uterus. They can have variable locations. It's not typically like our previous depiction described, or like you'll see in any of your textbooks. If you've done any amount of scanning, you know that they can be many, many different places. A female ovary, when a female is within her mother, she can have up to millions and millions of ova within each ovary during development. Once the female baby is born, they're down to about 1 million ova. So we start losing ova from the time we're in utero just till the time we're born. Once a female hits ages of puberty, which is typically considered around 10 to 12, about 300,000 will remain. So before we even become fertile, we've lost about 2/3 of our ova. Then after that, during each monthly cycle, a few oocytes will begin to start development and ultimately should lead to, typically in normal circumstances, 1 ovulation of 1 ova. Typically throughout a whole woman's lifetime, she will ovulate about 400 oocytes. Now, the female cycle is a very complicated process that includes, like I mentioned, the endocrine system as well as the ovarian system and the uterine system. And so we like to kind of break it up in 3 different cycles that are all going to occur at the same time. So our endocrine system is going to control the hormonal aspects of our cycle, and it's going to utilize the hypothalamus, the anterior pituitary gland, and the ovaries to control our hormones. The ovaries, aside from acting as an endocrine gland, in their gonadal roles are going to be influenced by follicular stimulating hormone and luteinizing hormone. it is going to develop an ova, and it's going to produce, as part of its endocrine responsibilities, it's going to produce and release estrogen and progesterone. The endometrium within the uterus is then going to be influenced by the estrogen and progesterone, and its role during this cycle is really to prepare for fertilization. Our hypothalamus, you see, is going to sit right here, superior and posterior to our anterior pituitary, which you see right here. Now, if we were to add the skull back into this brain, you would see that this anterior pituitary sits in just the sella turcica, which you would see very clearly on your lateral x-rays. So our hypothalamus is really going to be important in monitoring hormone levels and regulating hormones to be released. So it's going to collect physiologic feedback from the body's blood, so it's the monitor, and then if it sees deviation from homeostasis, it is going to stimulate the anterior pituitary to then go ahead and release specific types of hormones. It communicates with the anterior pituitary through a portal system. So rather than the hypothalamus releasing hormones out into the bloodstream where they would become very diffused or low intensity, it's going to have a direct communication with a portal system right here to the pituitary, and through a number of different surges, it is going to stimulate that pituitary. The portal system that we refer to here is called the hypophyseal portal system, and that really prevents dilution of the hormones in the circulatory system. Now, when that anterior pituitary gland is stimulated by the hypothalamus, it accomplishes that through the release of gonadotropin releasing hormone, or GnRH. So our hypothalamus releases GnRH through the portal system. That portal system then delivers it to the anterior pituitary, and that anterior pituitary, depending on the type of GnRH released, will then actually go ahead and release the follicular stimulating hormone, or the luteinizing hormone. Now, at the same time, our ovaries, in their endocrine capacity, will have receptors in the gonad to receive the FSH or the LH and act according to the directions of those hormones. When we are receiving FSH in the hormone, that is considered follicular stimulating hormone, and the ovaries are going to start to develop follicles. Luteinizing hormone is released later, as we'll talk about, and then it acts on a nearly mature follicle to promote ovulation. And our ovaries are entirely dependent on these hormones in order to be triggered to do the different functions of their gonadal and endocrine responsibilities. All right, so what we're going to start with, because we have three different systems running all at the same time, acting upon one another, and we refer to specific phases in each different system that are occurring at the same time with different names. So it can get very kind of confusing as we go through exactly how the three systems are working together to accomplish a normal menstrual cycle. So what we're going to start out here with is a very brief step-by-step process, and then we'll delve a little deeper into it in each of the system levels. So the hormone specifics. So on day one is the day a female would start her menstrual cycle. And what stimulates that menstrual cycle are very, very low levels of estrogen and progesterone. So low levels of estrogen and progesterone are recognized in the hypothalamus. The endometrium has already recognized these levels and started menses. And when the hypothalamus recognizes them, it is going to go ahead and stimulate through the use of GnRH. It will stimulate the anterior pituitary to start releasing follicular stimulating hormone. So meanwhile, we're releasing follicular stimulating hormone out of the anterior pituitary. Our estrogen and our progesterone are very, very low in our circulatory system. Our endometrium has detected those low estrogen progesterone levels and it's currently menstruating. The FSH then enters the bloodstream and then gets directed into the ovaries. When it reaches the ovaries are then going to initiate follicular development, hence follicular stimulating hormone. Now, as those ovaries begin producing follicles, the follicles will gather cells around them in which they will actually take on their endocrine properties. So the cells surrounding the follicles are going to begin to release an androgen or a male hormone, which is then converted into estrogen. So ultimately the follicle releases some estrogen. Now, in the first 7 days or so, one follicle is going to become the dominant follicle, and we're going to refer to that one as the Graafian follicle. And as we convert from multiple possible follicles to one Graafian follicle, once that selection is done, the estrogen levels are increased even more. Now, as our estrogen levels are increasing more and more, our endometrium is recognizing those levels and it's starting to regenerate the endometrium. As the estrogen continues to rise, those levels are going to be continually monitored by the hypothalamus. When it meets or reaches a certain benchmark or a certain level, the hypothalamus will trigger the release of something called luteinizing hormone from the anterior pituitary. Now, this luteinizing hormone is going to enter the circulatory system and again go act on the ovaries. By this point, the endometrium in the uterus is regenerating. The ovary has one dominant follicle called the Graafian follicle, and the luteinizing hormone is going to act on that Graafian follicle. It is going to increase the vascularity of the tissues surrounding that follicle and cause them to become so dilated that it ruptures, releasing the ova. And at this point, ovulation has occurred. Now, once ovulation has occurred, if we're looking still in the ovary, we'll find that that ruptured Graafian follicle is then going to degenerate into what we call a corpus luteum. The corpus luteum then is going to begin releasing progesterone with a little bit of estrogen. Meanwhile, our ova is being picked up in the fimbriae of the fallopian tubes and being moved very slowly toward the uterus by the cilia lining the tubes. The progesterone is going to cause the endometrium in the uterus to undergo what we call secretory changes. The glandular tissue is going to build up in there. The vessels within the endometrium are going to become much larger and engorged with blood and tortuous. Over the next 2 weeks, that corpus luteum is going to continue to release progesterone and estrogen, and our hypothalamus is going to detect those ongoing levels of estrogen and progesterone. And when it detects those elevated levels, the hypothalamus is going to cease to release the GnRH. Once the GnRH is not released into the pituitary portal, the pituitary will stop releasing any FSH and LH. So at this point, we've got high levels of progesterone and estrogen in the bloodstream, low levels of FSH and LH. The endometrium is becoming very glandular and echogenic, and the ovary contains this corpus luteum that is releasing the hormones, but over time is degenerating. Now, at the end of about 2 weeks of existing, that corpus luteum is going to degenerate all the way into what we call the corpus albicans. If no pregnancy has been accomplished, then the corpus albicans will cease to produce estrogen and progesterone. Now at this point, you're going to have a huge plummet in all of the hormones. You already have a low FSH and LH because the hypothalamus stopped their production, and now your corpus luteum is stopping production of estrogen and progesterone. So you have a plummeting of all the hormones. Well, the uterus of endometrium specifically are going to detect this, and the endometrium then will start to degenerate from its base and slough off. This will be the start of the menstrual cycle, day 1, which, as you remember from the beginning of the cycle, we talked about, which is also the day that the hypothalamus detects very, very low levels of all hormones and will then begin the whole endocrine cycle again. So that is your hormone relation to your endocrine, or pardon me, to your female cycle in a nutshell, and we'll go through it piece by piece here. So as we talked about, when the ovary gets stimulated by follicular stimulating hormone, it will start by acting at the follicular level. Within our ovary, we have oocytes, or that which will become the ova, genetic material partially prepared to go and create a new life. Now, when acted upon by follicular stimulating hormone, the ova will develop granulosa cells surrounding it. Those granulosa cells will then pull in theca cells from the surrounding tissue of the ova. It's actually these surrounding theca cells that will start to produce the estrogen. So theca cells are going to produce the estrogen. As you can see here, limited androgen production, and we talked about how androgen was converted into estrogen. Now, in the meantime, as this continues to grow and develop, there starts to acquire or accumulate some fluid within the Graafian follicle external to the oocyte. Now, once acted upon by luteinizing hormone, it increased the vascularity in the wall here. That vascularity causes it to become so edematous that it will go ahead and rupture, releasing the ova, and then it will degenerate into the corpus luteum and then ultimately the corpus albicans. All right, so estrogen. Estrogen, we're going to go over a couple of our hormones here really quick and not talk about just how they affect the cycle, but some other things that they're responsible for as well. So estrogen, as we've talked about so far, really is instrumental in stimulating endometrial thickness, and it also regulates the menstrual cycle. It promotes blood clotting, and it minimizes the loss of calcium in bones. Now, this is very important when you're working with patients that perhaps are thinking about getting a complete hysterectomy, removing both ovaries, and will no longer be producing any estrogen. It really increases their risk for osteoporosis and that type of disease, especially if they're not going to do any hormone replacement therapy. So it's important to remember that estrogen has a huge influence on calcium retention in our bones. The other thing that estrogen was really instrumental in our menstrual cycle is stimulating the luteinizing surge. Our ovaries are producing estrogen. Once they're producing enough estrogen, that's when we get that luteinizing surge that promotes our ovulation. If we're not producing enough estrogen, you won't get that surge, and therefore you won't have ovulation. There are 3 different types of estrogen in a female system. Estradiol, which is the estrogen we're typically referring to when we're talking about the menstrual cycle. This is the estrogen that's formed in follicles, the adrenals, and the placenta. Estriol is performed in the placenta only, and the estrione is throughout the body. Usually these are grouped and spoken of just in the general terminology of estrogen, but just to understand there are 3 different types. Progesterone, as we talked about, is produced by the corpus luteum after ovulation. Progesterone is really essential in progression of the menstrual cycle. It's also essential in being able to get through the early stages of pregnancy. It prepares the endometrium for implantation by causing it to become more more and more vascular, more glandular, and more a better habitat in case implantation occurs. It also decreases contractility of the myometrium, which means if something is, if a fertilized egg is trying to embed itself, that you wouldn't want the myometrium contracting, which could lead to a spontaneous abortion. It also is going to block new follicular development, so you don't continue to develop follicles during a pregnancy. It can change secretions in the vagina and cervix, making it easier for sperm to penetrate up into the endometrial canal. It increases your basal body temp, it inhibits lactation, and it decreases the maternal immune response, so that if you were to have a fertilized ova implant, then you would be less likely to have an immune response and reject it. Okay, luteinizing hormone, this is the one that is secreted by the anterior pituitary gland when we get very, very high levels of estrogen right before ovulation. So we get a high surge estrogen. That is going to stimulate the hypothalamus to detect that level, which will stimulate the anterior pituitary gland, which will release luteinizing hormone. Luteinizing hormone goes down to the ovary, acts on the Graafian follicle. The theca cells that we spoke of surrounding that follicle respond to the luteinizing hormone by secretion of testosterone, and that testosterone is converted into estrogen for one last surge. During that surge, the vascularity of the Graafian follicular wall is going to become very edematous and eventually rupture. Once it ruptures, those same theca cells are going to become the corpus luteum, which then will release low levels of estrogen, high levels of progesterone, and cause the endometrium to continue to develop and mature and prepare itself in case pregnancy does occur. Now, without the appropriate luteinizing hormone surges, you will never get ovulation. So this could have a significant impact on the ability to get pregnant. Now, here's where we're going to start kind of putting this all together. So in our upper level here, this is showing our ovarian cycles. So from here to here would be our follicular stage. We start out with an ova. We get a little FSH acting on it. It will produce a follicle. That follicle is going to progress. It's going to take in a little bit of fluid. It's going to attract those theca cells and the granulosa cells. Those cells are going to begin to produce estrogen, build up a little fluid inside, and then the most dominant one will continue to grow and produce more and more estrogen as the non-dominant ones will begin to degrade. So if we look at the hormone development as we walk through these different stages of the follicular hormone, you can see that originally we have very low levels of estrogen, very low levels of progesterone here in the purple, low levels of our luteinizing hormone in the blue, and of FSH in the green. And as we increase our FSH, you'll see our follicles begin to develop. As those follicles begin to develop, you see our levels of estrogen beginning to rise because they're actually releasing estrogen. As our estrogen begins to rise, once the dominant or Graafian follicle is selected, our estrogen production increases faster, and you'll see the estrogen move up faster. Now, our hypothalamus is watching this, and once our estrogen reaches that point, it will stimulate the release of our luteinizing hormone. Our luteinizing hormone really only acts for about 24 hours. When it acts on that ova, it hypervascularizes its wall, causing it to become edematous and rupture. So once rupture occurs, my luteinizing hormone begins to drop. During this period, my hypothalamus would have detected very high levels of luteinizing and follicular stimulating hormone. So it would have stopped the production of GnRH, which would cause that luteinizing and FSH hormones to drop. At that point, we've had ovulation occur and our corpus luteum is going to take over. Our corpus luteum is going to produce low levels of estrogen, as you see here in the orange, and high levels of progesterone. Those two levels are going to act on the endometrium to make those radial and spiral arteries more tortuous, add glandular tissue, making it become much thicker. As you see, the corpus luteum matures into the corpus albicans. It's going to stop the production of estrogen and progesterone, and you see when the production of those hormones is stopped, we start the menstrual cycle, and then we go back to begin the whole hormonal cycle one more time. Okay. Now, as you saw the estrogen and progesterone very, very low, we had menses occur. As my estrogen rises, I am going to increase the thickness of my endometrium, but not so much the tortuosity of those vessels. Now, once the progesterone starts to rise, that's when I have a lot of that increase in tortuosity, as well as the addition of glandular components into my endometrium. So it's during that progesterone where your endometrium really is going to mature. All right, now taking it back one more time, step by step, and we'll get you through this one more time, and hopefully it will feel a lot more second nature, and you'll know while you're scanning some of the specifics to look at. The other thing that you can that makes a big difference in really understanding these cycles is when people are having difficulty becoming pregnant or other issues. Sometimes tuning into what could be going on follicularly or with the endometrial maturity, things like that, can really clue you in to look for additional pathologies that might allow you to help your patients more. So if we're breaking this down into the endocrine cycle, the ovarian cycle, and the endometrial or uterine cycle. First, we're going to really talk about the ovarian cycle. So the ovarian cycle lasts from day 1 through day 14, meaning that day 1 of our cycle is the first day of menses, and usually assuming day 14 is about the day of ovulation. So ovarian cycle, we have oocytes containing partially prepared genetic material exist within our ova, or pardon me, within our ovary. Upon release of follicular stimulating hormone, those ova are going to be surrounded by a follicle. Okay. The follicle is going to develop around that oocyte, and it's going to develop cells called granulosa cells. And those granulosa cells that are going to arrange themselves around the follicle are going to start to secrete a very thick fluid called the zona pellucida. That zona pellucida is then going to attract free-floating theca cells that exist within the ovarian tissue. So we're going to have a new layer of theca cells surrounding this. Now this takes a little bit of time for the follicle to develop to this point. Once it's developed to this point and it has its zona pellucida and its theca cells in place, at that point it can start to produce estrogen. Now by day 7, so halfway through the ovarian follicular stage, all of these little follicles might be producing some estrogen. But after about day 7, one follicle is considered the dominant or the Graafian follicle, and these others will start to degenerate. However, that dominant or Graafian follicle will start to produce additional or higher levels of estrogen, and so this is when you're going to see those estrogen levels really begin to climb. Now, what do we know happens when we have that elevation in estrogen levels? We see the ovulatory stage kick in. So on days 14 through 15, as my estrogen levels really start to spike here, my hypothalamus is going to detect that. It's going to release GnRH into the the anterior pituitary, and that anterior pituitary is going to release a big surge of luteinizing hormone. You know that luteinizing hormone then is going to go act on that Graafian follicle, cause increased vascularity to the wall. That wall will become edematous and rupture and cause ovulation. Now at the same time, we're going to have that detection of high levels of estrogen and luteinizing hormone in our hypothalamus is going to shut those off. So when ovulation occurs, some people say that they can feel it. They can feel ovulation at one side or the other. The feeling of ovulation is called Mittelschmerz. Now, most of the time, if fertilization is going to occur, it's going to occur within the first 12 hours of release of the ova. So it's actually going to usually occur in that ampulla, as I pointed out on our anatomy diagram. So ovarian ovulatory stage only really lasts about 1 day. So days 14 and 15 during that luteinizing surge, that's going to be your ovulatory stage. Immediately after that, we enter the luteal stage. So we no longer have a follicle. It ovulated. Now we have a corpus luteum. So that ruptured Graafian follicle turns into the corpus luteum, and the degenerating zona and theca cells will go ahead and start producing progesterone with some estrogen. Progesterone usually peaks about 5 to 7 days post ovulation. Once it peaks, that that corpus luteum will then begin to degenerate to gradually become the corpus albicans and cease to release any hormones. Now, if fertilization happens to occur, that fertilized pregnancy will implant into the endometrium. At that point upon implantation, it will begin releasing HCG, or human chorionic gonadotropin. When HCG is released, it will act on that corpus luteum to tell it to go ahead and continue progesterone production until the first 10 weeks of life. So that definitely changes the process if implantation occurs. If implantation does not occur, the Graafian ovulates and changes to the corpus luteum. The corpus luteum eventually degenerates into corpus albicans, and our estrogen and progesterone levels plummet. However, because those plummeting hormone levels cause sloughing of the endometrium, it's essential that during pregnancy that the feedback from HCG prevents that decrease in progesterone and estrogen, so that the endometrium does not slough off until the pregnancy is fully adhered. Okay, now, so that's mostly the stages of our ovarian cycles. If we look at the uterine or endometrial stages that correlate to those ovarian cycles, we can group them into 3 categories. The first is the menstrual phase or stage, the proliferative phase or stage, and the secretory phase or stage. Now, just beware that proliferative and secretory can be referred to as early proliferative and late proliferative, or early secretory and late secretory. I grouped them together just for simplification purposes, since you're already progressed into your career. All right, so the uterine menses stage, this is going to correlate with the early ovarian follicular stage. So as all hormones begin to plummet, low estrogen and progesterone will cause degeneration of the endometrium at the radial artery level, right there basically at the interface between the myometrium and the endometrium. And when those arteries begin to necrose, they will cause the endometrial tissue to slough off and menses will begin. It's as menses begins that the hypothalamus does detect those low estrogen and progesterone levels, and it stimulates the anterior pituitary to begin FSH production. However, FSH production does not immediately lead to estrogen levels increasing. And so those days of low levels of estrogen and progesterone allow for time for the endometrium to fully slough off. Now, day 1 of the menstrual phase, usually your endometrium will be a little bit thicker, but something like you see maybe in this image with a little bit of fluid in the endometrium, a little bit thicker, but by day 5 or the end of the phase, you should see only the interface of the anterior and posterior endometrium together. So it should measure about 1 millimeter or less than 1 millimeter at the very end of the menstrual phase, which should be around day 5. Now, because during day 5 or during those first 5 days, that hypothalamus detected those low hormone levels, it has been releasing follicular stimulating hormone, and throughout those 5 days, that ovarian development of follicles has been occurring, and now estrogen will start being produced and released. When we start seeing that elevation or increase in estrogen, that's when the next stage will begin. And we call that the proliferative stage or phase, and more specifically the early proliferative or late proliferative. So this would be the early proliferative. Now, the entire proliferative phase or stage lasts from day 6 to day 13. So this is the stage that's going to take us from menses to ovulation. So as soon as menstruation stops, we are technically into the proliferative phase. Now, at this point, the FSH is acting on the ovaries. The ovaries have follicles developing. The follicles are releasing estrogen. Estrogen is acting on the endometrium, causing it to thicken. It's causing the regeneration of those spiral arteries of the endometrium. Now, at the end of our proliferative phase, we end up having ovulation in the ovaries, and that will send the endometrium or the uterus out of the proliferative phase and into the secretory phase. Now, a couple other things are happening towards the end of our proliferative phase here. The Graafian follicles releasing higher levels of estrogen, so you'll see the thickening of that endometrium occur more quickly. However, it still stays very hypoechoic, as you can see in this image here, because it's not secreting a lot of glandular tissue, and the spiral arteries are not tremendously tortuous at this point. The other thing that these higher levels of estrogen do during the proliferative phase is that it's going to increase cervical mucus, and that cervical mucus is going to make it easier for sperm to get up into the endometrium to increase the probability of fertilization. So at this phase, the endometrium begins this phase as very, very thin, just that 1 millimeter line that we saw at the end of the menstrual phase. And throughout the phase, it's going to thicken, and it will stay relatively hypoechoic. Now, right at the end of the phase, only for about 48 hours, right before ovulation occurs and progesterone starts to be released, you see what we call the 3-line phase, or the 3-line sign, where you see the basilar portion or the interface between the myometrium and the endometrium on one side, the endometrial interface in the middle, and then the myometrial endometrial interface on the other side. And we call this the 3-line sign, and this demonstrates a patient is very close to ovulation. Now, once ovulation occurs, we move our patient into the secretory stage. So when ovulation occurs, that Graafian follicle collapses in on itself and becomes our corpus luteum. Now, our corpus luteum is going to produce a lot more progesterone than estrogen. So that progesterone goes down and it acts on the endometrium, and the endometrium is going to cause the cells of the endometrium to become, or the arteries of the endometrium to become much more tortuous, as you see, and it also causes that accumulation of glandular tissue there. Now, if the cells, when that elevation of estrogen and progesterone gets so high, they're going to act on the GnRH the hypothalamus, which will reduce GnRH production, and so LH and FSH will occur. Now, if fertilization does not occur and those hormones all plummet once the ovary or transitions that corpus luteum into a corpus albicans, once that all plummets, you'll see a necrotic change here at the base of this spiral artery, and all of these arteries then will of course then be eliminated, and that would be the end of the uterine menstrual cycle as soon as menses starts again. Okay, so really tying this all together, we talked about how we really have three components of the female cycle: the ovarian cycle, the endocrine cycle, and the uterine cycle. And we really have to concentrate on how these act all together. So we'll go over one last brief overview, and then hopefully you'll feel really comfortable. So first thing that happens is the start of our menstrual cycle, we have very low hormones. We have very low FSH, very low luteinizing hormone, low estrogen, low progesterone, and our endometrium has had these radial arteries necrose and die off, and so that the whole tissue can then slough off during the menstrual cycle. Now, as all of these hormones here have plummeted, it has stimulated the hypothalamus to tell the anterior pituitary via the release of GnRH, hey, it's time to get going again. So the anterior pituitary is going to release a follicular stimulating hormone. That follicular stimulating hormone is going to go and it's going to act on the ovary. The ovary will then produce a follicle around an existing ova. That follicle is going to gather in granulosa cells and it's going to gather in theca cells. And as it does that, while the endometrium is sloughing off, it's going to be gathering these cells. About the time the endometrium's done sloughing off, those cells are going to be prepared to start producing estrogen. So you're going to see via the ovary, your estrogen is going to begin to rise. And as your estrogen rises, your endometrium begins to thicken. Now, also as that estrogen rises, this is where we're transitioning from multiple follicles to a single Graafian follicle. And as we select that single Graafian follicle, once it begins to put all of its energy into maturing that follicle, our estrogen levels are really going to peak. So we have a Graafian follicle, which is large and in charge. We have estrogen that's peaking. We have our endometrium that's thickening. Now, my hypothalamus is going to recognize this high level of estrogen, and it's going to trigger the production of GnRH, which will act on the anterior pituitary. The anterior pituitary will then surge that luteinizing hormone. The luteinizing hormone is going to go to the ovary. It's going to act on that ovarian wall, causing increased vascularity. That vascular wall is going to become engorged and basically rupture. Rupture causes ovulation to occur, and now our ova is going to go into our fallopian tube, hopefully. Now, this high level of luteinizing hormone and FSH is going to be detected by our hypothalamus, and it is going to turn off the GnRH, which would mean the levels of those two hormones are going to start to decline. Meanwhile, in our ovary, that Graafian follicle that just ovulated is going to degenerate into the corpus luteum. The corpus luteum is going to start producing high levels of progesterone, low levels of estrogen, and those levels of progesterone and estrogen are going to act on the endometrium, causing them to thicken, causing the radial arteries, spiral arteries to become more tortuous, and causing an increase in glandular tissue. As that occurs, they're going to become more and more echogenic. Then, after about 7 days, when our progesterone meets its peak, it's going to start tapering off as that corpus luteum starts to transition to the corpus albicans. Now, as it tapers off, it produces less and less progesterone, less and less estrogen. All of a sudden, we're down where we started, where all of our hormones are very, very low. And that is going to cause our radial arteries to, our spiral arteries to necrose, and to degenerate and to slough off, and the whole cycle to start again. So, thank you again for joining me for this first lecture. I hope it's something that you can find a little bit useful in your practice and in preparation for any credentialing exams you might be considering taking. If you have any questions, please reach out to me. Hopefully from this lecture today, you will remember that the menstrual cycle includes the ovarian cycle running in tandem with the endometrial or the endometrial or uterine cycle. The positive and negative hormone feedback systems are essential in both cycles. GnRH, LH, FSH, estrogen, and progesterone are all very important parts of the menstrual cycle, and each hormone change causes significant response in other systems. So I look forward to moving through the next topic in our class next week, and I hope you have a wonderful week.